Top Med Talk.
Welcome to Top Med Talk. This piece has been supported by an unrestricted educational grant from bioMérieux.
Hi, I'm Sandra Kane-Gill, a professor at the University of Pittsburgh in the School of Pharmacy. And today I'm talking about health system perspectives in acute kidney injury. My objective for today's talk is to discuss a deliberate commitment by health systems to optimize kidney health and improve the outcomes of patients who are at risk for or who develop acute kidney injury during hospitalization. There's a call to action. In 2019, the U.S. Department of Health and Human Services developed a document, a plan, for national goals targeted at improving the care and outcomes of patients with kidney disease. This included preventing and reducing the number of Americans who develop end-stage kidney disease by 25% by 2030. So this document had other goals as well, and these goals were more focused on chronic kidney disease. But that doesn't mean that this goal is focused on chronic kidney disease. If you think about this, an opportunity to prevent end-stage kidney disease is going all the way back and preventing the acute kidney injury from ever occurring, right? Because there's this relationship between AKI to CKD progression and then progression to end-stage kidney disease. Also, this sounds like a very U.S.-centric goal, but clearly this goal is not just U.S.-centric. It's not just a U.S. problem. Kidney disease, including transitioning from AKI to CKD, is clearly a public health concern, with devastating patient outcomes that requires immediate responsiveness by the medical community in all nations. Thinking about this transition from AKI to CKD, we reflect upon the definition of AKI. AKI being this abrupt decline in kidney function within 7 days. Then thinking about the definition of CKD, which is the abnormality of kidney structure and function for greater than 3 months. The time between AKI and CKD is known as acute kidney disease. So if you think about it, if you prevent the AKI from ever occurring, or if you intervene at the time of acute kidney disease, you could prevent that progression to CKD on this continuum. And this is very important because 20% of patients with no history of CKD who experience an episode of AKI will progress on to develop an episode of de novo CKD. This rate gets even higher at 40% in patients who have and develop acute kidney injury that requires dialysis. This evolution has been demonstrated for various etiologies, including cardiac surgery, sepsis, and AKI due to nephrotoxicity. Interestingly, 6 months after an episode of drug-associated acute kidney injury, about 70% of patients have evidence of residual kidney damage. There's a thought that, patients who recover from acute kidney injury at the time of hospital discharge are less likely to progress on to CKD. But that's not true. There's evidence to suggest, recovery or no recovery, there's an opportunity to progress. Now, it may be higher in those patients who didn't recover, but still, both have progressed. Some studies support patients experiencing a more severe episode of AKI or a longer duration of AKI, that those individuals have a greater chance of progressing on to CKD. But there's studies that provide contrary opinions to that. Residual kidney damage has been noted and up to months after the insult and even up to years after the insult. So this progression is important, and it's important to think about where there's an opportunity to intervene, where the best interventions can occur to prevent that progression to CKD. So how do we respond? How do institutions respond? How do health systems respond, right? They can develop a strategic approach to determining their level of commitment, seeing where they're at and their level of commitment towards kidney health, and deciding how they want to change or progress in that commitment. And if they want to change and progress, that requires developing an organizational plan for change. So some of the goals that can be achieved are early detection of acute kidney injury to prevent its occurrence, right? And that can be accomplished with the use of clinical decision support, or possibly these newer, more novel biomarkers can help in identifying those high-risk patients. Another goal is, AKI detection as soon as possible, because that can help to prevent complications, reduce severity, reduce the duration of acute kidney injury. Again, another opportunity for clinical decision support surveillance. A third goal can be for those patients who develop acute kidney injury that the follow-up is better, and maybe during that time of AKD they don't progress on to CKD. But all this requires health systems to develop structured, sound implementation projects with intentional implementation interventions that meet these goals. Here's a ranking for kidney health commitment. The ranking that I'm proposing here is, if there's not a structure, if it's not strategic at the institution, that all healthcare professionals address and manage patients who are at risk for or who develop acute kidney injury in their own manner, without strategic initiatives, that would be considered a very low commitment. And then if the commitment by the institution is more reactive, when a patient develops AKI, there's opportunities to intervene to prevent progression, but the AKI has occurred, right? And so that's, of all the efforts are directed at those who develop AKI, that would be more of a reactive response, a low level of commitment. Moving up towards prevention, towards finding the best ways, the best interventions, the best detection systems to find those patients who are at high risk for developing acute kidney injury, develop strategic approaches to intervening so the AKI never occurs. That would be a moderate level of commitment. And then moving on to think about post-hospitalization and better care and follow-up for these patients who developed acute kidney injury, in addition to use, those moderate and low levels of commitment. That, combining those three would be a high level of commitment. Now, really, there's an appreciation that institutions don't necessarily sit in just one category. They could be doing some things in low and some things in high. But to really consider yourself progressing from one level to the next, it would require that the institution decides all the things they want to do to achieve a reactive response, all the things they want to do to achieve a preventative response, all the things they want to do to achieve a follow-up response. And once they've identified and delivered and optimized all of the responses in one category, then they can rank themselves as a higher category. Again, realizing they may be doing some across these different categories, but not really ranking themselves as complete until all of the things they wanted to accomplish in each one of these categories is done. So I mentioned that these novel biomarkers could be an opportunity for helping to prevent progression to CKD, right? And so this figure is that continuum that I showed previously, but now at certain time intervals, I've interjected the possibility of evaluating biomarkers. Okay? And so before there's a rise in serum creatinine, but just after kidney insult, biomarkers such as NGAL, TIMP2, IGF-BP7, and KIM1, if they rose, it could indicate a subclinical AKI, suggesting this risk for, high risk for a patient to develop acute kidney injury, an opportunity for earlier intervention. You could also use other biomarkers, such as PenKid has been looked at to predict patients who are at risk for persistent acute kidney injury, and also at risk for worse short-term outcomes. And this has been measured within 24 hours of admission for a patient who has sepsis. You can monitor CCL14 to assess for risk for persistent acute kidney injury in a patient who already developed stage 2 AKI. Within 36 hours, CCL14 has been measured and has been suggested that it can reveal patients who are at risk for persistent acute kidney injury. From a perioperative perspective, biomarkers such as monocyte chemoattractant protein 1, DPCOF3, and epidermal growth factor have been tested and measured just before surgery and then follow up after surgery to find out and predict those patients who are at risk for worse and short and long-term outcomes. So obtaining this better understanding of potential prognosis could allow for a more aggressive management strategy, more aggressive monitoring, and even application of treatment if it were available. So in summary, I'd like to say that there's been a call to action to improve the care and outcomes of patients with kidney disease. Health systems can respond by providing a high level of commitment towards ensuring the best kidney health for all patients equally. And also, health systems can be very deliberate in their change, providing implementation interventions that are sustainable and scalable and potentially generalizable. Thank you for your time today.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.